Good morning. First of all, I would really like to thank Dr. Satya for giving me this opportunity. So, I'll be talking today about the SIOP-RTSG umbrella protocol for Wilms tumor. Is it really feasible in the Indian scenario? We all know that Wilms tumor is one of the commonest renal tumors in children, and there is a lot of disparity in the outcomes between the high-income countries vis-a-vis the low-medium income countries. And in the HIC, they have, because of a good multidisciplinary care, they have more than 90% survival rates, 5-year survival rates, which is excellent, and that should be our aim. The probable reasons could be early detection, standardized treatment protocols, and of course, comprehensive supportive care. I found this article very interesting, talking about the global disparities in Wilms tumor, and if we look at the differences here, they're really stark. In the LMICs, despite having larger number of cases, the survival rates are poorer, and some of the reports from sub-Saharan Africa are just showing 11% to 46%. Probable reasons, we all know, we've been there, we've worked with these children, and of course we have late presentations, limited access to healthcare facilities, lack of standard treatment protocols. I think this is also there because everybody does whatever they feel comfortable with. And then, of course, we have a high rate of abandonment here. I looked at some of the studies from India, and this was a very nice systematic review done by Dr. Maya and her team, in which they have looked at a total of 17 studies, and they actually searched the SIOP abstracts as well for 14 years, and selected the studies which had more than 10 patients, and almost 1,170 patients they have reviewed, and I could say this is kind of representative of the India data. And the range is, survival rate is 48 to 89%. So there is a wide variability within centers here itself. And this is another study that I found by our Secretary General and his team. And this is a very good number, 156 children. However, survival rate for 2 years was only about 36%. So there's a lot of variability. And I know each one of us, when we treat Wilms tumor, we're given our best, but we don't get that outcome. So we have to look at how we can try and improve this. This is a personal communication. This is an INPOC study, a retrospective multicentric study, and total of 404 children from 16 centers over a collected data of over 10 years. And surprisingly, this data has got better outcome, 5-year event-free survival rates of 85.9%, which is really not bad. So this study is not yet published, that's why I'm not showing any graphs and all. Unfortunately, in this study, I don't think any of the AIMS or TMH were involved. So they were most smaller centers with less than 50 cases per year, but they pooled in their data together to see. So I'm just thinking what made the difference in this last study. Probably a multidisciplinary care, because all of them had a pediatric hematologist oncologist in the center, and this was done through the INPOC. And of course, standardized treatment protocols. Most of us follow either COG or SIOP, and we try to go with the protocols. But there are a lot of variations. Whenever we are faced with a challenging situation, we sometimes just bend the protocols because whatever is comfortable, we just do it, or whatever is feasible, or whatever is available. Things may not be available according to the protocols. And of course, we need a lot of support from NGOs for financial and logistic aids. So that's why I thought we'll just talk a little bit about this umbrella protocol. What exactly is it? It was started in 2016. And the main mission is to increase the survival as well as to reduce the acute treatment toxicity and the late effects in children with renal tumors up to 18 years of age. So the other thing is it aims at providing the same standardized high quality treatment as well as diagnosis to all children, irrespective of the geographical place from where they come and what is their socioeconomic group. So this is in accordance with the WHO Health for All, as well as the aim for, close the care gap for international childhood cancer. So there are two parts. That's a site where you can find more details. And I'm sure I'm not going to go into details. There's not much time. So the part A tells us who's eligible, and the part B tells us details of the treatment protocol. And they have all details about surgical, radiation, side effects, toxicities, chemotherapy, everything, and including RCC and other tumors, renal tumors as well. Now, what they want to do is they want to create some new biomarkers, which could be image-defined, pathological, as well as molecular. So all three. And this is going to be important not only for those with a poor prognosis, but also for excellent prognosis patients, because their treatments will be decreased. And mainly it involves real-time central reviews of the radiology and pathology, as well as standardized assessment. So this is the data management, ALIA data management, into which we have to feed the data. And they also want to store the samples for biomarkers, which could be used later on. 1Q gain, the most important thing in the molecular, and the volume of blastema. So how they are going to calculate this volume of blastema, and they're going to see if it correlates with the survival and as well as the molecular markers. So for this itself, the central pathology and central radiology review is important. So the central radiology review, what does it mean? It is real time. That means it's not going to be done after 1 month. It has to be done as soon as the patient comes, right? So we have to upload the DICOM images, send it to the central radiologist who is going to review, and they have to send it back within 24 to 48 hours so that we can start the treatment. Similarly, pathology review, this is for after surgery, and we need to also store the tissue for biomarkers. So the 1Q gain can be done by Wilms MLPA, which is available. It's a low-cost, rapid turnaround, and it can be done both on frozen as well as paraffin. So we don't have to do really on the fresh samples. So why this blastemal volume is important? Because they found that almost 40% of relapses occur in children whose tumors were not initially marked as high risk at diagnosis. And that's why we need to further qualify and see which are these patients we need to identify, and we need to intensify the treatment for them. I'll just finish. So basically, they want to optimize the definition of this absolute blastemal volume. And what is proposed is about between 20 to 50 ml, right? And then a lot of discrepancy has been seen in the central radiology review, and that is why we need to do a central review. And also we need to see the response to preoperative chemotherapy with the help of 3D volumetric assessments and MRI if that is desirable, but they will do it for CT as well. So I will just come to what exactly we need to do, minimal requirements. One is that we need to provide all the data. We need a central pathology review, central radiology review, and that's it. Of course, molecular is also desired, but the tissue banking is desirable, but it's not mandatory. So the biggest challenge for us is getting the central pathology review rapid within the stipulated time of 14 days. I'll just finish it to one slide. And again, in central radiology review also, we need a challenge because we may not have DICOM images all the time, and we don't want to repeat the imaging for a small child. So MRI is desirable, but the team, we have discussed with them, and they say, as long as you mention why you couldn't do it, that is fine with us. So this is just showing how detailed the pathology review is. We've already done some work on this. We've identified a core team, and we have coordinated with the main team, and we've identified centers for central pathology and radiology review, and this is the core team. And we are just waiting for the funding to go ahead for the central pathology review, which is going to be, we are hoping to get the ICMR funding, and let's just wait. Thank you so much. And let's just reinforce with the help of example of Wilms tumor that childhood cancer is curable, and we have to try and strive to improve our outcomes. Thank you.